I think I'm going to start. We have questions that have been asked already from our audience during registration. And in reading through them, there's a kind of theme on the adult care questions, asking what's available and why there's not adult care, and how can patients access it. So there's been, and I'll make a couple of comments on that, and then we perhaps can move on to some other topic. The Weinberg Family Cerebral Palsy Center does provide care across all ages, including adults. And we have established a registry which now has about 6,000 lives, including half kids and half adults. And we're working hard to try to provide information about care for adult patients with CP. The truth is that there are very few, individual providers, groups, or specialty caregivers that make a specialty or that even have a real interest in seeing adult patients with CP. So we're trying to build that. And with my amazing faculty and with and particularly with the addition of Dr. Selber, we're hoping to expand our services to adults with CP. Paolo, do you have any comments about that, please?
As I said before, I'm very, very humbled and thrilled to be here. I will try my best to bring to Colombia some of the stuff that we have been doing in Melbourne for the last nearly 20 years. And one of the things that, as you all know, I'll push very hard is so that we establish a motion analysis lab in the facility so that we can start applying all the knowledge that we've gathered from gait analysis over the last 30 years between myself and all the other gait analysts and people dedicated to this area.
So the other comment, we had several comments on strength training and exercise. And I know that I loved Dean's comments tonight. I wonder whether, Dean, maybe you can give us a feeling for how you approach that delicate proposition about how much stretching is really needed and how much strengthening is needed and how they should be prioritized.
Okay, well, again, many of our patients are very tight, but I think we've seen over the years that just that static stretch isn't sufficient. So I try to make their stretching something where it's more active. If you look at our NDT type activity where you're asking the muscle to be active, and then when it relaxes, you try to get them to move into a place where they have more extension, if that's what you're looking for. I'll give you an example. I'm better at example versus just going through the literature. If, let's say, you have a child who has, or an individual, it doesn't have to be a child, who has tight hamstring. It's a simple example, but I think it brings my point to bear. If they tighten their quadricep, neurologically, it asks or it tells the hamstring to give some relief, to give some relaxation. So in strengthening our patients, if we get them to the point where they're at almost the limit of the hamstring length, but not there yet, so they have some ability to move, then we ask them to tighten that quadricep and lift the leg. If they're on their back, knee flex slightly, leg up in the air, and you ask them to activate that muscle that opposes a tight muscle, you are giving them the ability to relax to some degree the hamstring and get some more range. The child I showed who was going up the ramp, looking at gastroc versus tibialis anterior, when she's going up a ramp, she has to dorsiflex or at least get that toe to clear to get up the ramp. So we're weight bearing through the limb that we're trying to stretch. we're actively using the muscle that opposes the gastrocnemius to get the foot up in the air for that step, and she's doing something of her own volition. Yes, there are some patients who initially aren't able to do that, and I think Dr. Kim, she's been very helpful with us who have patients who either that tension, that spasticity overcomes so much of their movement that they can't even activate the other muscles. So the benefit of something like Botox is that if there's a muscle that's so strong in its spasticity that it cannot be overcome by either passive stretching, which is not my favorite, or active activity by the patient, that Botox gives you a window. It could be 3 weeks, it could be 3 months, depending on the patient's response. But in that window, you teach the patient what they can do to activate the muscle you're trying to get them to utilize that opposes a tight muscle. And then when the Botox starts to wear off, at least they have a window or space or step into the direction that you're working on. But again, this all takes time. And I think we've learned over the years that when you know where you're headed, it's not such a difficult thing to take the time to get there. And I said about that other individual who wants it to happen now, things don't happen now. I mean, you surgeons know those things happen immediately. Surgery happens immediately. But I know you've all said to us that that's not always your primary thing to do. There are other ways to address what's going on with the patient. So the immediate look to have something happen immediately may not be the way to go, but be aware that it's a marathon. It's not a sprint. These kids it takes time to get where they are. So it will take us time to move from where they are to a better place. Hopefully that answers some of the questions.
Thanks a lot, Dean.
Thank you very much.
So I have a question about a child with diplegia, age 8, who's not able to get heels down even in braces. Dr. Kim, what conservative methods do we have of helping that child achieve a plantigrade foot?
Are you asking me questions? Or?
Yeah.
Or could you, because I couldn't hear you well.
Yeah, the question is, there's a question about an 8-year-old with spastic diplegia and inability to get the heel down even with bracing. And what conservative techniques would you recommend to achieve a plantigrade foot?
Right. So thank you. 8 years old patient must have some contractures, I think. It's already 8 years old. But I would suggest that my primary treatment option is a local approach, which is botulinum toxin injections or alcohol nerve blocks. So we don't need to make all other places weak, but only focus on spastic area. So if sounds like this patient has more spasticity in the gastrocs and or soleus rather than hamstring or hip flexors. So let's, if I assume that most of the spasticity in his or in her gastrocs, I would suggest that based upon how much patient has contractures, but I will go with the botulinum toxin injections and possibly recommend castings afterwards.
Can I add to that, please?
Mm-hmm.
We're talking conservative methods, so that's definitely a way of getting that improved. The other thing with that Botox, if you find a way to support that patient's heel, so if it's a reverse wedge, if it's some way of getting some support under their foot when you're working there, they don't have to be down, but they need to feel that sensation of that heel on a support surface. Otherwise, they're always trying to push into the ground to get their trunk to stay up. And I'm assuming this child's an ambulator. So if, as the Botox is doing its job, you can get them to weight bear through the heel, then it actually allows them to relax a bit and not always try to activate those muscles that you're trying to get to stretch or to relax. And if that chain is a little bit better aligned with some heel contact, you can work on the muscles and the alignment above at the knee and at the pelvis at the same time.
I just would like to make a comment about these. To say that a child doesn't touch the heel to the floor, even in AFO, is a bit concerning to me, because there's a gait pattern called apparent equinus. In other words, the child is apparently on their toes. And in these patients, what actually happens is that the hamstrings are a little bit spastic, very rarely shortened, just a bit stubborn, as I call them. And because they cannot extend the knees fully in what we call the mid-stensive gait, that gives us an apparent impression that the heels are not touching the floor. And they're actually not touching the floor, but it's not at the expenses of the plantar flexors or the gastrocnemius. Rather, it's an issue up above with the hamstrings. So in these patients, we need to be careful, because if we weaken the gastrocnemius or soleus too much, and the hamstrings are already hyperactive, this is a recipe for crouch gait. So whenever you have someone on their toes, even in AFOs, pay attention to what's happening to the knees in mid-stance, or when the leg is right on the floor, and see what's happening to the knees. That might give us more information. Thank you.
Thanks for your comment. I think I didn't explain too long, but I totally agree with you that we will check the patient knee flexor and hip flexors. Most of my cases, I never ever do injection to gastro only. We always prefer multi-level injections. So this case, if the patient came to me, I'm sure I will, already 8 years old, I will pick the iliopsoas hamstring, more so medial side of the hamstring, and gastroc. I wouldn't touch the soleus at all, because I have the same concern that the patient may develop the crouch gait or crouch posture. So I think we are on the same page.
Yes, I agree.
So I'm looking at our at the time, and we are well over time. My coaches for this webinar said, well, you need to wait until you see the crowd is going away. And I have to say that people that are interested in CP are really interested in CP, and they're passionate about this topic. And we're still getting questions, and we still have a kind of a crowd here tonight. So the drop-off has been minimal. But I do think, though, that we need to respect each other's time and your time. And I will promise you that we will be back. We're going to ask you for topics that you want covered. We now have a long list of unanswered questions from many people in the audience that we will work hard to get back to you about, and perhaps try answering those questions in future seminars. So I think we will, at this point, we can say good night, and thank you all for attending. Good night.
Thank you very much.
Right.
Thank you very much.
Thank you.
Thank you.